Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Welcome to Dental Webinar Series. Today we have the privilege of having Dr. Uvoh in the house today. Dr. Uvoh is a clinical professor of dentistry at the University of Michigan. He received his DDS from Schumbok National University in South Korea and his certificates in prosthodontics and a master's from University of Minnesota. And he also did a fellowship in maxillofacial prosthetics from the UCLA. Prior to joining the faculty at University of Michigan, he served as the assistant professor of dentistry at the University of Florida. I was a visiting professor of dentistry also at the UCLA. Dr. O teaches various activities, including predoctoral students in the comprehensive care clinics, and he also course director for the removable prosthodontics at the predoctoral and graduate levels. His research interests are in the area of prosthodontics, developing new protocols for prosthodontics procedures, dental ceramics, color, and dental implants. Thank you so much for joining us today on this webinar series. Welcome to the program, Dr. O.
Thank you, Uvoh, for kind introduction. Good morning, everyone. Thank you very much for joining this session. Today, I'm going to talk about very basic stuffs about removable partial dentures. Talk about removable partial denture abutment selection and design. These are very basic stuffs, but I still believe this is very important topic, especially in terms of designing partial dentures and also enhancing the success of partial denture treatment. With enhancement of oral hygiene, nowadays we may see a decreasing number of edentulous or partial edentulous patients, but actually because of the aging population, we see actually the number of partial edentulous patients. And I looked at some of the papers, and that they have reported most of the partial edentulous patients are managed with the removable partial dentures instead of implants or cantilevered fixed partial dentures. So I think this topic can be quite interesting for us today. And first, I'd like to talk about abutment failure, the failure rate of abutment for removable partial dentures compared to fixed partial dentures. And this is one of the study that looked at abutment survival up to 19 years, a clinical study retrospective, and they looked at almost 3,000 teeth in 148 patients. This study was conducted in Japan, and they found out RPD abutments showed a significantly higher failure rate than fixed partial dentures. Having said that, if we look at those two, the patient photos, our RPD patient shows less number of teeth remaining, and usually usually partial dentures are used to manage when patients present with less number of teeth are remaining and when missing span is long. So there's a great leverage effect applied to the remaining dentition, especially a primary abutment and also secondary abutment. But also, we often see failure of the bridge because of the post-dislodgement or fracture of the abutment. Oftentimes, we see a ceramic failure too. But basically, this study highlighted the failure of abutments can be greater when patients receive removable partial dentures than fixed partial dentures. And one of the factors that we need to look at, because the abutment failure can be higher with partial dentures, and one of the factors could be looking at crown-root ratio. And this is a 7-year clinical study to look at survival of almost 850 abutments for 236 partial dentures. And they have found out when a crown over root ratio is a greater than 1.5, which would be almost 50 or 60% bone loss below the CEJ, the survival of the abutment can be dramatically diminished. So we need to look at the crown ratio. And actually, we do quite well once we take a radiograph and we can measure from the top of the occlusal surface and then the bony crest area, which would be clinical crown, and then we can measure from bony crest to the apical portion of the roots, compare the root ratios. The only interesting factor that we need to consider is if the tooth is vital or non-vital. And this study looked at, again, 5-year survival rate of the abutments of fixed partial dentures versus for removable partial dentures. And if you look at this data is very interesting. 5-year survival for RPD abutment was only about 51% compared to 92.7% for fixed partial dentures, especially if the abutments were restored with the post and core. They did not specify the type of the post or core, but in general, they reported either prefab or cast post and core. So there must be something if the abutments have lost the vitality and also restored with post and core, even though the abutment was protected with a full coverage restoration. So we did a systematic review to look at what's going on behind. And this study basically looks at 7 clinical studies that have reported the survival of the abutments. And we compounded all the data that compounded for almost 1,000 RPDs for 800 patients. And we have found out the failure rate of the non-vital abutment was almost 13% versus a 4% for vital abutments. And the difference, almost 3 times a greater risk of failure of non-vital abutments, regardless if the abutment was restored post and core or not. So when we have the abutment that has lost the vitality, then there must be a red sign, and I think we need to pay attention to that. And I'd like to share a few patient cases with you. And this is one case that was done with one of my students. And if you look at one premolar that was restored with a prefab post and core, and then a full coverage PFM restoration was placed, and then you can see mesial rest was prepared. And then this patient had received class 1 mandibular partial denture. And then clasp assembly, as you see here, you may appreciate a stress breaking or stress releasing type of clasp assembly, although you may suspect the absence of indirect tension. But our very interesting, the finding was that the patient came back one day after denture placement. So the photo was taken at 24-hour follow-up, and the abutment was broken already. So that was quite a learning experience to me. And this is another patient case that shows a class 2 with 1 posterior modification. And you can see second premolar was restored with cast post and core and then PFM restoration was placed. And also that tooth was sitting next to free end side. We developed mesial rest, and then clasp was designed with I-bar and then distal proximal plate, which is a stress releasing design. And this patient presented 1 year later, and you can see the abutment tooth got broken down at gum level. And basically, roots was fractured along the axial in a vertical direction. Also, the poster came out per se with the crown. So the treatment got failed. So we may say, yeah, this partial denture was for the mandible, and also the abutment was sitting next to the dental span. So there must have been a great amount of leverage, and then the abutment must got torqued, so it got broken. But if you look at this patient case, you may appreciate a different perspective. Look at the tooth indicated by arrow, and the tooth is basically engaged by short span upper partial denture. And you can see only one tooth was replaced by partial denture. Yeah, this is 6 years follow-up. So someone may say, oh, the partial was greater than 5 years, so it may be okay. But may not be okay considering success or a survival of fixed restoration, including a full coverage, a single crowns. Their survival rate is much greater than 6 or 5 years. And the tooth got anyway, the broken down at gum level. Originally, the tooth was restored with prefab post and core, and then built with the PFM crowns. But somehow, the tooth got broken at gum level with that short span upper partial denture. So I think we gotta be very careful in terms of selecting the abutment, especially if the tooth is non-vital, and also that has been built with post and core. But having said that, we may suspect that then what we are going to do if the tooth is non-vital, are we going to remove that? No, that's not my point. My point is that we need to look at other factors. We need to look at edentulous span. If the edentulous span is long or short, or if the edentulous span is bounded or a free end. And also we need to look at residual dentin. Many of our in vitro studies have showed if we have uniform 2 millimeter ferrule height with 1 millimeter dentin thickness, the survival of the tooth is going to be a greater than less than 2 millimeter. But in reality is that the ferrule is not really uniform in many of our patients, and most of the time the height of the ferrule is less than 2 millimeter. And also, when you look at the thickness of remaining dentin, may not be a 1 millimeter. And also, we need to appreciate patient bifurs, at least by looking at the Frankfurt mandibular plane. Some patient may present greater than more acute gonial angle, or some patients may present less acute gonial angle. So we can look at that. And also, some patient may present hypertrophic mascatory musculature. If that's the case, we have to pay more attention to that. And the other factor may be how we are going to design post. We can select a prefab post and core, or we can design cast post and core. And this patient case shows that one tooth sitting in the back, and this post was designed to engage a 3 canal. One is palatal aspect and 2 on the facial aspect. And since the canals were divergent, those posts were designed in 2 segments and then joined by dovetail fashion and then cemented. And this type of restoration, as long as there's a good ferrule height and good thickness of remaining dentin, as long as covered by crown, and I think the survival is greater than just a teeny or a slender prefab post that engages on one canal, especially when ferrule is compromised. So once the abutment has been selected, then we are going to start preparing a guide plane. A textbook states that the first step that when we are modifying the abutment is going to be a guide plane, because if we start with rest sit prep first, then after preparing a proximal surface to develop guide plane, the outline of the rest sit is going to be altered. So we have to revisit the rest sit prep again after developing guide plane. So it would be wise to prepare a guide plane. Usually the guide plane is placed on mesial proximal or distal proximal surface. And we like to get that proximal surfaces as parallel as possible, but at least slightly divergent, because we are not really milling in the patient's mouth. We are using handpiece. So everything is done manually. So at least the guide plane should be as parallel as possible, but at least it should be slightly divergent toward the occlusal aspect. So there is no undercut there. And actually guide plane, multiple guide plane will enhance significant amount of indirect retention. When we talk about indirect retention, we may think about anterior occlusal rest that goes anterior to the line. And that is one factor of indirect retention. But by increasing the number of indirect retention, there is a greater surface area in terms of contacting between the tooth surface and then proximal surface of the proximal plate. So basically increasing the surface area of contact between guide plane and guide plate, which is proximal plate, we can enhance frictional retention, which is a part of indirect retention. Having said that, we can develop a guide plane into two different fashions. One would be a long guide plane. That means guide plane is going to be developed from the marginal ridge at the occlusal aspect and also going down all the way near the free gingival. That means guide plane is going to be quite long and wide to increase the frictional retention and also by increasing the surface of contact. But one thing that we need to pay attention is that when we are designing a free end based RPD, if the guide plate or guide plane is for sitting next to it, free end edentulous span, then we need to look at very carefully so there is no binding upon occlusal loading between a proximal plate and guide plane. If a binding is noted, we need to relieve the proximal plate so that the abutment is not torqued by the occlusal loading. Or alternatively, we can develop a short guide plane. Usually the guide plane is confined at the marginal ridge level about 2 to 3 millimeter down in gingival direction. And there's a small gap at the gingival embrasure so that when there's occlusal loading applied to the free end denture base area, the denture base is going to rotate in gingival direction, but still the proximal plate is not going to bind against the guide plane. So this system, it can be safer when designing a free end partial dentures because a stress braking system has been built in already. So let's say if your patient is old and may have a difficulty of coming back to your clinic regularly, you may develop short guide plane so that there's a less chance of torque applied to the abutment. But also when you are designing a class 3 partial, if you want to enhance or maximize indirect retention, then we can design a long guide plane, especially when you are designing a surveyed crown. We're going to talk about that later, and then we can develop a long guide plane to maximize indirect retention. And then the next step would be creating rest sit. The rest sit must be positive. And that means inner aspect must be lower than at the marginal ridge. so that the force goes in axial direction. But sometimes it will be very difficult to develop a positive russet, especially if you are creating russet on mesial of mandibular first premolar because of the occlusal morphology. What is really important is that just to make sure that the russet is basically is developed to resist the gingival displacement, I take perioprobe and then press down against the russet in gingival direction so that to confirm that if the perioprobe is being slipped in gingival direction or stays there. If it stays there, that means there's a good resistance to prevent a gingival displacement of a denture. There would be a good positive russet. So it can be fashioned in two different patterns. One can be more like a ball type russet, as you see in the upper corner. You can use a number 8 or number 6 round burr to create a round depression. And also you can I like to use, if you go to a textbook, the textbook states that you take inverted cone burr to create a latch type over the cingulum. I tried many times, doesn't work well for me. And I like to create all the corners rounded. So I take actually moderately heavy chamfer burr and approach from the incisal direction. And also the burr should be lined up with the path of placement of denture so that there is no undercut in the axial wall of the russet. So basically you can create a latch over the cingulum, which is more like inverted V shape, or sometimes you can fashion in a more linear pattern. When we think about the location of occlusal rest, we were told go to mesial side, especially if you are on next to edentulous span. That is one concept that is suggested by and also advocated by most of the authorities, and I like that. But we need to really look at the occlusal contact relation. Mesial pits sometimes can be heavy in terms of occlusal contact, and if there's a good space on the distal pit, you may often select distal pits. Again, it depends. You need to look at many different clinical conditions too. But basically, occlusal rest can be developed on next to edentulous span, so that there is no risk of foot impaction. If there's a gap between approximate plate and guide plane, the foot can get there, and there must be a decay developing. Sometimes we may see a gingival inflammation in the papilla. And if you look at one occlusal rest sitting on one of the canine, that canine russet was added just to ensure that the lingual bar can be more stable. If we delete that or remove that occlusal rest, then lingual bar is going to be really long from canine to first premolar, which would be to distal of first premolar. Then the lingual bar may move in up and down with the under chewing function, and they can irritate the lingual mucosa in the anterior segment. So we like to keep that major connector stable by adding just one more occlusal rest. Also, this is more important actually in terms of determining the location of occlusal rest or lingual occlusal rest. Somewhat correlated with the occlusal contact. Some of your patient may present with deep anterior overbite. If that's the case, we need to look at the location of lingual occlusal contact. And then we need to develop russet at gingival to the lingual occlusal contact, especially if we aim for a palatal strap that is extended from the palatal aspect and cover over the cingulum. And this is one of the mistakes that was made in our student clinic. And you can see how deep is the overbite. And then we developed lingual latch somehow incisal to the lingual occlusal contact. You can see the small latch that is indicated by arrow in the upper left corner. And then somehow we did not detect the error until the completion of the partial denture. So partial denture was delivered so that there's a deflective occlusal contact that goes against the cingulum rest in the anterior, and then denture teeth was functioning each other. But then you can see premolars, which would be the abutment for upper and lower partials, and they are not occluding each other because the OVD has been altered by means of partial denture. So this is not really sound dentistry. But occasionally we can develop the lingual latch at the incisal to the lingual occlusal contact, especially if the abutment is sitting next to edentulous span. And this is one case you can appreciate how deep is the anterior overbite. And there is no room that we can develop cingulum latch at the gingival to the lingual occlusal contact. So the plan was to create the russet at the incisal to the lingual occlusal contact. So I would say, again, this would be an exception, so that the cingulum rest is extended from the distal proximal plate instead of extended from the palatal aspect, such as a palatal strap. In that way, we didn't have to change the patient's occlusal vertical dimension. And this is what patient sees, actually. No matter what we do, patient doesn't know dentistry. They always look at their teeth. And if you look at the one side of the remaining teeth, they were covered with PFM restoration, and then we were replacing with denture teeth with partial dentures. So when we have to match with plastic and porcelain, that is quite difficult, but luckily it turned out quite well. And also we have to pay attention to match the pink acrylic, so that in SMILE, although this patient didn't show much of pink acrylic, and also, so we actually have to look at the color of pink acrylic, also look at the profile from the lateral aspect. And we want to make sure that the gingival architecture matches with the counterlateral ones. And this is what patients see. So when we deliver partial, they are going to immediately see and SMILE, and they are going to attempt to talk. And if they are not feel comfortable in terms of feel and also the look, they may not like no matter what we do. We have to remember that it's the patient who's going to buy the partial denture. So appearance is really important. We emphasize all the time with partial denture, OVD should not be altered, but sometimes we have to alter, or we may have to alter the OVD. As a prosthodontist, what we see is that we see a room or space, the space that is available for fabricating dentures. We need basically space to build something so that we can restore and also function. This patient presented with only 4 teeth and the remaining in the top. And then the OVD was somewhat collapsed in terms of interarch space. Interarch space was very narrow and limited, so we had to really increase the OVD. If that's the case, then we have to ensure that the occlusal contact goes uniform all across the arch. So if you look at the left-hand side, you can see the occlusal contact is in the front, and also occlusal contact goes in the back. But the patient may feel kind of instantaneous or transient confusion when partial denture is in and out, because without partial denture, OVD is going to be slightly lower, but then OVD will be slightly increased with the insertion of partial dentures. But most of the patients actually adapt well as long as the OVD change is less than 1.5 millimeter. Actually, for this patient, the OVD change was only about 1 millimeter or 1 millimeter half millimeter, because we need a space for a palatal strap to extend over the cingula. So very, very small amount. And this is what I like to do, especially when patients present with heavy anterior overbite. I like to use articulating paper and then mark the lingual occlusal contact first, and you see where you can develop a cingulum rest or lingual occlusal rest or latch type or concave ball type rest. The shape doesn't matter, but we need to find the location of the russet that we can prepare. Basically, we like to stay away from the lingual occlusal contact area. And also textbook suggests that we gotta do diagnostic mounting, but in reality, because we are so busy every day in our everyday practice, diagnostic mounting may not be practical for all of our patients, although sometimes we have to do it because of complexity of the case. So this clinical procedure will give us a pretty good idea where we can actually develop occlusal russet or lingual occlusal russet. And I'd like to share one mistake again we made. This is one of our student case, and you can appreciate anterior missing in the maxilla, and also there's one posterior modification. So you can describe this as a class 3 and 1 modification based on kinetic classification. And then if you look at one side as indicated by arrow, we basically designed embrasure clasp. As embrasure clasp is designed to cross over the occlusal embrasure, but then we developed the russet on those 2 molars will not adequate. So basically the minor connector and clasp basically was extended above the occlusal plane at the of occlusal embrasure. So if you look at the left-hand side, you can see that the occlusal rest and embrasure, occlusal rest and minor connector basically extended above the occlusal plane. When the framer was placed in the patient's mouth, the patient cannot bite all the way down. You can see how big is the anterior open bite. And oftentimes we may attempt to do enameloplasty on the lower, but certainly this amount of anterior open bite cannot be resolved by doing enameloplasty on the opposing dentition. So we have to make sure that whenever we design occlusal embrasure type of clasp assembly, we have to make sure there's a sufficient room. So this is another patient case. You can see a occlusal russet was prepared between 2 mandibular molars. A textbook may say, yeah, we have to develop at least a 2.5 millimeter in width and 1.5 millimeter in depth. But even though sometimes the space may not be enough, because we want to make sure that the clasp assembly in that site is durable enough to resist the occlusal stresses. So oftentimes if it is really heavy, sometimes we have to do some enameloplasty on the opposing dentition. And also later we are going to talk about that. We have to make sure that there's a good undercut for clasp assembly. Oh, yes. Now I think we can, since we have developed a guide plane and russet, now we can look at axial contour. Or alternatively, you can develop guide plane and do axial contour and then russet at the end. That maybe actually would be better because we are going to never forget creating a russet, but oftentimes, especially when we are constrained in terms of chair time, then we may ignore or can be sometimes negligent in looking at the axial contour. So anyway, when we are looking at the axial contour, this illustration basically shows the facial aspect showing the height of contour. The height of contour is basically, if you look at the left-hand side, you can see on distal facial, the height of contour is usually very occlusal, especially when you are looking at a circumferential type of clasp retainer as shown on the right-hand side. The initial 2/3 of the circumferential retainer should be above the height of contour. If the height of contour is so occlusal as shown on the left-hand side, then the clasp assembly is going to be so sometimes it can interfere the occlusal contact against the opposing one, and also at the same time, because of the short length of the clasp arm, it can be quite rigid and may torque abutment. And if you look at the clasp arm as shown on the right-hand side in a curvilinear fashion, so 2/3 of the initial 2/3 sits pretty much at the middle, and also a terminal third is tucked into the undercut. And if you look at the terminal third actually swings up in occlusal direction. So even though this is a circumferential Akers clasp, the way how the tip of the retainer works is more like mimicking infrabulge clasp, which is I-bar. So this is more like a push type instead of pulling type. So the retention can be more efficient, even though this is in general pulling type a clasp assembly. The point is that we have to shave distal facial so that height of contour can be apicalized in gingival direction further down into cervical area, so that we can have 2/3 initial portion goes in the middle, and that gives a good stability for the partial framework. So this is one patient case that shows how we designed a clasp assembly. If you look at a distal facial usually is more occlusal in terms of height of contour. So we basically shaped a distal facial to lower the height of contour in gingival direction, and then prepared some concavity or depression on mesiofacial to ensure a good amount of undercut for retention, and then framework was fashioned in that way. So we all want to make sure that the clasp arm does not interfere against the occlusal contact, and also the clasp arm sits away from the free gingiva, and also like to make sure that the clasp arm goes against enamel instead of against cementum, because cementum is more susceptible to wear, but enamel is has much better characteristics in terms of resisting the wear induced by a clasp arm. And also make sure that when we are designing clasp arm, we want to make sure that there's a less amount of metal display so that the patient can accept the partial denture. In this case, the gingiva was quite receded in apical direction, so cementum was exposed, and that's why you see that if you look at the distance from free gingiva to clasp arm, there is a good amount of distance, but we wanted to make sure that the clasp arm goes against the enamel. But clasp arm should be at least 1 millimeter from free gingiva, and make sure that the clasp arm goes against enamel. I don't play golf, but some of you may play golf. If you look at the surface of golf ball, there's a lot of dimples. And I looked at the depth of dimples. The depth is about 0.1 millimeter. 0.1 inch, which is 0.25 millimeter, which is recommended depth of undercut by the textbook. Again, it really depends on how we tilt the cast, or depends on the tilt of the abutment. Some of the teeth are upright. If that's the case, it would be more straightforward. But other teeth may be tilted, especially when we are looking at a mandibular facial axial surface. Some of the mandibular posterior teeth are really tilted in a lingual direction, and then there is no undercut at all. And there are two different ways. One is subtractive, the other is additive procedures. Subtractive is basically what that means. We can create the undercut using a burr. Usually I like to use a number 8 round burr so that I can approach from the occlusal aspect and create some type of some depression or concavity. Or sometimes I use a round-ended bully type burr but I prefer a round burr because I can approach from the occlusal aspect. Or alternatively, if there's a significant lingual tilt of especially mandibular premolars or canines, if that's the case, then we may have to add some composite so that we can reshape the facial axial surface and then create an undercut at the gingival to the height of contour. This is one in the fashion how I like to develop for eye-bar. If you look at the facial axial of that canine, you can see kind of oval shaped dimple so that the tip of the eye-bar can be tucked in. Even though the tip of the eye-bar is tucked in, actually the very tip of the eye-bar matches with the height of contour so that, or maybe slightly below the height of, no, I'm sorry, I made a mistake. The very tip of the eye-bar can match with the height of contour, but then still, because of the depth of the dimple, the good portion of the terminal of the eye-bar still is tucked into the undercut, and then there's a good retention there. And then also when the partial is removed and the eye-bar, instead of digging into the enamel, can be displaced gradually without catching or digging into the enamel. And that way, the removal can be more gradual, and then there's a less a chance of wearing of the enamel. Sometimes, sometimes we may just cut the very terminal of the eye-bar, especially if the eye-bar does not engage the undercut. And that way, the eye-bar goes into the undercut, but then the very tip of the eye-bar may sit way far below the height of contour near the gingival aspect. If that's the case, there is no good stability, and removal can be abrupt. Sometimes it can dig into the enamel when attempt to remove the partial denture. So we like to get that very tip of the eye-bar lined up with the height of contour, but then about 2 millimeter surface contact into the dimple. Again, if there's a undercut presented by the natural facial contour, we don't really have to create oval shape. What I'm talking about is if there is no undercut, then we have to shape that. And then the way how I like to fashion for Akers class is I like to create like a channel type concavity or depression. In this case, the clasp assembly arises from the distal occlusal embrasure site and then across the mid-facial axial and then engage mesiofacial. So if you look at mesiofacial of that first molar, you can see a channel type undercut, which would be about 0.01. It should be greater than 0.01 or should be less than 0.02. It should not be greater than 0.02 inch undercut. Someone has a question. Let me open that up. There are specific indications, contraindications to RPD. Specific, so talking about indications. So at the very beginning, I talked about the fixed partial versus removable partial dentures. Removable partial dentures are usually indicated for a freehand situation, especially there is no tooth in the back there. But also if the span is long, even though there's a last molar is remaining, then we can go with the removable partial dentures. And also RPD treatment is less expensive. So we need to look at the patient's financial situation. Fixed partial denture is quite expensive. And also the patient's medical history, systemic condition, their past history. Some of our patients don't like removable partial dentures because of bad experience, previous bad experience. If that's the case, we may seek alternatively implant restoration. But there's a limitation with implant restoration because of sinus pneumatization, also atrophic ratio, especially in the mandible. There's IAN crossing in the posterior region of the mandible. Sometimes we have to do the bony augmentation for implants, but then it can be quite expensive. The vertical augmentation doesn't work well on A type. So that is one consideration too. Hopefully I addressed that answer, but I don't know how I can, my cursor doesn't work. So anyway, let's just keep on going. This is one case that actually we prepared undercut on mesiofacial so that circumferential retainer goes into the undercut. Somehow it doesn't work. Okay. No. Oh, okay, now it works. So this is the way how we designed. We planned basically to have a curvilinear pattern of a circumferential retainer. We prepared undercut on mesiofacial, but somehow turned out that way in a more linear fashion so that the clasp arm does not engage undercut. You may see this quite often in your clinic. If that's the case, we have to make a decision what to do. Are we going to make impression again, or we are going to cut that clasp arm and then recast and then weld it, or we are going to recontour that? Actually, for this patient case, because of other issues, I tried to recontour, and this was my best. I could not really recontour as I planned, so it didn't work. Retention doesn't work. Didn't work, and then the way how the clasp arm was contoured, it's just going from the occlusal to gingival direction is more linear pattern, and the retention was not efficient. And also when we are recontouring, there's a risk of fracture, so we got to be very careful and have to work intimately with a laboratory technician. The other, this would be my almost the final stage of my presentation. Oftentimes, we ignore the facial axial contour when we are making final impression for framework fabrication. So no matter what is given to our lab technician, they are going to engineer and then fabricate the partial framework. So this clasp actually does not engage the undercut at all. So if that's the case, most of the time we just bend in with plier, and then but then there's a frictional retention when we bend in just by tightening. But then since the clasp arm does not go into the undercut but sits actually above the height of contour, there is no after a while the clasp arm is going to fade out, bend out, and there is no retention. So to avoid that, this is one of my suggestions, and you basically sit that framework in the mouth and then use a regular lead pencil and draw the outline of the clasp arm, and then remove the clasp from the patient's mouth and take a diamond burr and then create the undercut following the outline as to the clasp arms. And then you are going to bend in using plier, and then everything will turn out great. In that way, the way how the framework goes is passive. And also, guide plane should be above the height, but most of the time, if you look at the lingual axial, the lingual axial is more rounded, and height of contour is way close to the occlusal aspect. If that's the case, we need to actually extend a proximal guide plane slightly toward the lingual, or sometimes we can even develop a latch on the lingual axial. Especially if you are planning for surveyed crown, as you see here, we can mill the lingual axial along with the proximal, and then the lingual bracing arm can be sit on top of the lingual latch in a fashion that to make the partial simple, and then there's a good support by the bracing arm and rest. This would be my last one. And very often time, this is the way how surveyed crown is returned from the lab. So since this crown was surveyed by the lab technician, we like to trust without looking at the details of the occlusal anatomy, also facial and proximal axial surface, we attempt to just cement it on. But then if you look at closely, you see how small is the occlusal russet, how occlusal is the facial axial contour, and then so indistinct, so small a guide plane. So we can actually take, so if you do, if we accept this contour of the surveyed crowns, then our partial framework is going to turn out like that, which is not really ideal. So before we cementing on, we can refashion using diamond burr, just like as if we are preparing the abutment, and we can refashion the occlusal russet and increase and make the guide plane more distinct. And then we can fashion mesiofacial to lower the height of contour. And then we can create some channel type undercut on distal facial, because the distal facial was not really fashioned to present some undercut there. And that way, we can have distinct rust and then a good guide plane, a good circumferential retainer to ensure stability and retention for that. I think that's all what I have today. Actually, I have a couple more, but I like to stop because of the timing. And actually, Dr. El Abrashi is waiting for next presentation. If any of you have a question, actually, let me go to Q&A. I can open that. So one question is that there are specific, okay, there we addressed that. The second one, tips on overlay frame denture for the tooth abutment that would be on the bottom of the overlay. Should we contour? Yes. We like to create russet, either a ball type, concave russet, or latch type. We like to make sure there's a good support, and also in that way there is a force goes in axial direction, not in labial direction. So yes, even though we go over the lingual axial, we like to create some russet. And the next question would be, thanks for one. Thank you. Highlights common mistake in RPD. Worst by many dentists. Okay, thank you for a last comment. And
yes, Dr.
Uvoh, do you have other questions?
Yeah, there's a question here on the chat. It says, does post and core increase the chances of stability, or does it weaken the tooth further? So when you use it as an abutment, I guess.
A post and core is basically to retain the crown. So if there's a good amount of residual dentin remaining, and we can look at and evaluate, sometimes quite difficult to anticipate, but at least we have to inform the patients. And we like to be conservative as much as possible, as I suggested, even though the post and core is used to build partial denture abutment, the partial, we can still build partial as long as we provide information to our patients. I like to design cast post and core for anteriors. Prepared post and core can be used for premolars and molars, but if there's a less than 2 millimeter a non-uniform failure height, then I like to go with a cast post and core most of the time.
All right. All right. Thank you so much. There's one question here. It says differentiate between a guide plane and proximal plate. I think pretty basic question though.
Difference between guide plane and proximal plate?
That's a question here.
difference between guide plane and proximal plane. A guide plane is a proximal surface that is developed to determine path of placement that is prepared on tooth abutment. And proximal plate is a part of a partial framework. So proximal plate is going to approximate against the guide plane.
Guide plane. Okay. Cool.
Yeah.
All right. Well, thank you so much, guys. This has been recorded, so I know this is pretty a lot of information for some people, but this is something that we all need to go back, because you need this for your practice. So the
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator